I would like to welcome everyone to the Minnesota Gerontological Society webinar. I'm really looking forward to the presentation today, and I'm sure all of you will learn a lot today. I want to thank you for your participation and let you know that this webinar is a co-sponsored event from the Minnesota Gerontological Society and the University of Minnesota Center on Aging and MAGIC. And MAGIC is the Minnesota Area Geriatric Education Center. My name's Tom Hyder. I'm going to be your moderator today, and I also serve as the Executive Director of the Minnesota Gerontological Society. You can get more details about MGS and all of our webinars when you join or look at the MGS website, mngero.org. If you go to the website, just click on the webinar panel, and you'll see handouts from all of our past webinars and information about upcoming events. We record all of these webinars and we upload them to the MGS YouTube channel. Access to this channel and all recordings, however, is only available to MGS members. We think this is a great reason for you to become a member because in addition to these videos, you get free CEU certificates of attendance for attending these webinars and a very substantial discount to the 2015 MGS conference. Again, you can find all that information on our website. Now, I want to share a few logistics with you about today. If at any time you're having any audio issues, on the right-hand side you can switch between telephone or the mic and speakers on your computer. So make sure that the audio works and know that you can switch back and forth. All of your audio is muted. If you have a question for the speaker, please feel free to type the question in the question or the chat box. It'll either be on the right-hand side of your screen or down at the bottom. I'm going to be monitoring all of these questions, and from time to time I'm going to break in and ask the question for you. If you have questions after the event, please know that you can email us at info@mngero.org, and I will be sure to pass those on to the speaker. Immediately after the webinar, after you close out, an evaluation or survey is going to pop up on your screen. We're very interested in learning what you liked, what you didn't like, and what your ideas are about future webinars. Also, if you want CEUs for today's event, or if you want information about joining MGS, you must fill out those questions on the survey, and we will get back with you then. Now, I'm very, very pleased to introduce our speaker today, Jan Mueller. Jan is the Vice President for Governmental Affairs at the Alzheimer's Association, Minnesota, North Dakota. She's worked there since 2008. She has over 25 years experience in the administration of government programs. She's the designated lobbyist for Alzheimer's Association public policy effort and serves as the lead staff on the Public Policy Committee. She serves on the National Alzheimer's Association Public Policy Advisory Council and played a very active role in the development of Act on Alzheimer's, where she serves on the steering committee. Jan's the chair of the Minnesota Healthcare Action Network, and her current work includes advancing the Healthy Brain Initiative, a joint effort of CDC and the Alzheimer's Association. I am very pleased to introduce to everyone here Jan Mueller. Take it away, Jan.
Thank you so very much, Tom. I'm honored to be here, and I'm grateful that everyone has registered for this event. So we are here today to talk about the Healthy Brain Initiative. We call this the roadmap. This is a public health roadmap for state and national partnerships. You're seeing the book itself on the screen right now. This is part of a 5-year effort with the CDC, a cooperative agreement to really work and advance Alzheimer's as a public health initiative. So when we think about the Healthy Brain Initiative, the first roadmap was published in 2007, and the years following that advanced the National Alzheimer's Project Act in 2012, and then eventually a national plan to address Alzheimer's was first published in 2012. The new edition of the roadmap then followed in 2013, and it's that new edition that we're going to be talking about today. So the guiding principles of the roadmap addressing cognitive functioning along a continuum, really making an effort to address cognitive functioning from the very earliest stages of memory decline through the end of the disease, while at the same time having a commitment to promoting health equity and always staying grounded in science. So we're talking about Alzheimer's today as a public health crisis, and not too long ago people would not have looked at it that way. So why is Alzheimer's a public health crisis? Well, first of all, it's number 6 of the leading causes of death. It's the only cause of death in this top 10 without a treatment or a cure. In 2013, 5 million individuals were impacted by the disease, having been diagnosed. And by 2050, we expect that number to rise to 16 million. The original book, The Healthy Brain Initiative from 2007, is now appearing. Then the National Plan. The National Plan to address Alzheimer's disease is the result of the National Alzheimer's Project Act, passed and signed into law by President Obama. That requires a yearly update that goes to Congress and to the White House and the administration. The World Health Organization also has made dementia a public health priority, and they also come out with a yearly report. And then here's the most recent Healthy Brain Initiative, the Public Health Roadmap that will be used 2013 through 2018. So the roadmap itself had a process that you see on the screen, beginning with planning the generation of the ideas, trying to determine the structure, and then how the roadmap would be interpreted. To do that work, there was input from more than 280 experts, and that resulted in 35 actions recommended to the public health community to do over the next 5 years. So the roadmap has a traditional public health structure to it. You see the assessment, the policy development, and the assurance. The roadmap is then divided into 4 domains. The first one I've added is monitor and evaluate. Again, a typical public health arena. Educate and empower the nation, a very important part of this work. Developing policy and mobilizing partnerships. And the last one, assure a competent workforce. So the roadmap is broken up into these 4 domains and has 35 action items that are divided up into these domains, each one with a letter and a number that equates to which one of the 4 domains we're talking about. So first we're going to remind you again that we're talking the core functions of public health. And we're first going to talk about developing public policy and mobilizing partnerships. While I don't know everyone who's listening to my presentation, I'm really hoping that this webinar today will be yet another way that we mobilize more partnerships in Minnesota. So in the recommended steps for developing policy, the first one is PO1, to develop, implement, and maintain a state Alzheimer's disease plan. Alzheimer's disease plans were first suggested in state governments in 2004, and there were several states in 2004, 5, 6, and 7 that started those disease plans. Minnesota passed legislation in 2009 that created an Alzheimer's disease plan for the state of Minnesota. So we have worked on PO1 already. For PO2, PO2 is where you integrate cognitive health and impairment into your state and local government plans, such as the aging plan, the chronic disease plan, the transportation plan. So of these 2, we can currently check off PO1. We have significant more work to do in PO2. To reflect on PO1 for a moment, some of you may be aware that in 2009 the state plan was developed by the work of the Alzheimer's Disease Working Group. That work then transformed itself into Prepare Minnesota for Alzheimer's by 2020, and they have evolved again and have changed their name to Act on Alzheimer's. Act on Alzheimer's is the current evolution of the state plan in Minnesota. P03, the incorporation of cognitive health and impairment into the state and local public health burden reports. Alzheimer's is a tremendous burden to society, to families, to finances, and incorporating that burden into those reports is another step that we have ahead of us. P04 is a step addressing the Healthy People 2020 objectives. So it's really only in the last year and a half that Alzheimer's and dementia has been included in the National Healthy People 2020 report. We've been working to have inclusion into the Healthy Minnesota report as well. We're going to go on now to another area of the roadmap called Educate and Empower the Nation. P03 requires a recommendation that there's linkage on all state and public health websites, linkage to Alzheimer's disease resources, and that would include the Alzheimer's Association at alzheimers.org and alzheimers.gov. E07 refers to the promotion of advanced care planning and advanced financial planning for care partners, families, and individuals. That's a very important recommendation of the roadmap. In Minnesota, there is some work already being done in that arena. Own Your Own Future has certainly made some very effective work there, and we have to continue to work on that. Alzheimer's disease is the most expensive disease in America, and advanced care planning and financial planning is very important to families. E08, a very interesting one that we don't talk a lot about, but increasing local participation in clinical trials on cognitive health and impairment. That is something that Minnesota is doing slightly better than many of the other states, but again, we have a lot of work to do there. Monitor and evaluate. For those of you who are currently working in public health, you're certainly familiar with this area of the public health arena. MO1, one of the most important recommendations of the entire roadmap, suggests that we will implement the behavioral risk factor surveillance system and include in it cognitive and caregiver optional modules. It's those modules that really provide data in terms of what is going on across the entire nation at any given time. MO2 is where you use the data that comes out of the BRFSS survey and actually use that surveillance data to enhance your public health programming. MO6, you then further include that data in local needs assessment. So where are we on all of this? Well, again, we can check off MO1. Minnesota has taken strides to include the cognitive and caregiver modules. It's important that Minnesota continue that work. And we have not yet used the data from that work as much as we could. In looking at the local needs assessments, there's also a great deal of work to be done there. Act on Alzheimer's is doing a lot of work in communities across the state. They now have 32 communities that are in some form of evolution to become a dementia-competent community, and much of this information could be useful there. So I'm showing you now a map of the United States. Many of you may be aware that the color of the Alzheimer's Association is purple. This 2011 to 2014 map represents a real push to turn the United States purple. And as you see, we did not quite succeed in that effort. But with this surveillance being taken every year we can certainly advance it further. So I'm going to show you some data here. This is actually taken from the 2011 behavioral risk factor surveillance system. And let me say that the data from the 2012 was just released in the last couple of weeks, and I had already submitted the slides. But it's very similar data. So from the 2011, we saw that 12.9% of people 60 and over reported memory loss. We showed that 80% of them had not talked to a health provider. 1 in 3 say that their memory loss has interfered with their household activities or their work, and that 1/3 live alone. In the new data from the 2012, the first bullet would be 12.5. So 12.5% of people 60 and over reported the memory loss. In the new data, 77% had not talked yet to a health provider, and that's critical information. So if you think of how important it is to really get early detection and diagnosis, to have percentages as high as 77 or 80% that they have not talked to a physician is quite concerning. 1 in 3 saying that the memory loss has interfered. It interferes with their household activity, with their actual income provided work, and all parts of their lives. 1/3 live alone. That number is expected to increase over the next 10 or 20 years as well. As the baby boomer population moves forward, there is expected to be a higher percentage of people with the disease actually living alone. The next section of the roadmap that we'll talk about is assuring a competent workforce. So the first bullet there is WO3, supporting efforts to educate the healthcare providers about the early signs of dementia. Healthcare providers in this arena could be everything from physicians, it could be students in the medical schools, nursing students, other types of healthcare providers. It's also very important in WO6 to educate healthcare providers about the validated cognitive assessment tools. There's certainly confusion that there are good assessment tools available and well-trained individuals who can do that detection and diagnosis. So what can public health do in all of these situations? Well, there are linkages that can be provided on the public health agency websites. Some of that has been done already. And in these bullets here where I'm talking what public health can do, I don't wish to minimize what the health department has already done. A great deal of effort is already underway by the Minnesota Department of Health, but the roadmap indicates that these are areas that more can be done across the nation. The second bullet, the integration of cognitive health and impairment into the relevant state and local government plans is very important. The transportation plan needs to include Alzheimer's and dementia. I believe the aging plan currently does. The Falls plan, I think, is in process of adding that. Public health can also play a role in care coordination for persons with dementia. The legislature in 2015, I expect, will be looking at this particular item in a bit more detail. Care coordination has been identified as an area that the entire nation can do a great deal more work. The big bullet might be this next one, increasing public awareness about dementia and promoting early diagnosis. Public awareness campaigns are very expensive, and certainly we at the Alzheimer's Association have never been able to fund the cost of a major public awareness campaign. That was a strong recommendation that came out of the Alzheimer's Disease Working Group when they created the Minnesota State Plan. So the promotion of early diagnosis is very critical. Early diagnosis is important in a variety of ways. If there's early detection and diagnosis, the person with the disease can often participate in their future planning. They can participate in financial planning and have their voice heard in what they would like in their end-of-life care. Supporting continuing education efforts for healthcare providers, again, a very important area that the public health community can provide assistance. There's new information being released certainly every year and very frequently during the year about Alzheimer's and dementia. So continuing ed becomes a very important part of the work. Offering counseling to individuals and their care partners, another area where the public health community can be effective. The care partner working with anyone with dementia is the all-vital person. The caregiver often experiences heavy burden by caring for their person with the disease. They not only have a financial loss, they have a burden in 24 hours a day of their world. Trying to find ways that the state of Minnesota can invest in the caregivers will be a heavy area of work being done again in the 2015 Minnesota legislative session. Educating healthcare providers about the cognitive assessment tools, again, a very important role that public health can play. So in summary, what we need to do in the roadmap for the BRAIN initiative is to really ensure that we better understand the public health burden and that we monitor trends over time. The most important thing that we can do to monitor those trends is to use the behavioral risk factor surveillance system. And those two modules are very important. We're certainly hoping that they will be used in further years in Minnesota. So that concludes my formal presentation.
And I'd just like to let everyone know that you can ask questions of Jan by just typing in the question box, and then I will pass them on to you. Jan, we did have a question emailed to us earlier from Bill Weir, and I'd like to forward that question to you. Excellent. For those of us who have seen the new documentary film Alive Inside, or learned of the Wisconsin Department of Human Services adopting and recently expanding its program of personalized music, as demonstrated by music therapist Dan Cohen, how best can BRAIN Initiative incorporate these findings in the treatment of Alzheimer's and other dementia?
Thank you, Bill, for raising that question. I don't know how many of you have seen Alive Inside. It is a tremendous film that demonstrates the usage of music therapy and demonstrates how individuals with dementia respond when headphones are placed on their head and they hear familiar music. I know that our education department is currently examining that film and looking at ways that that information can be shared and can be used. I'm sure that as professional education is delivered, I'm sure there'll be much more discussion of the work of music therapists and how that work can be included. I think that film is still available in the Twin Cities. You might want to check your local movie listings. Last week I noticed it was still showing. So any of you who haven't seen it, I would suggest you try to get to that film.
We have another question from Professor Sue Humphreys-Ginther, who happens to be the co-president of MGS out in Moorhead. Welcome, Sue. And Sue asks, what do you think can be done to attract more people to work with older adults and increase gerontological expertise?
Thank you for that question. I know that we have tossed that question around a bit ourselves. Certainly we know that the cost of pursuing a career as a geriatrician or in gerontology is expensive. There have been suggestions of certainly student loan forgiveness and other ways that it could become more attractive. I think it's also part of the public awareness campaign. We need to really stress to the nation how important it is to study the world of aging and to become a professional in that field. So I welcome all of you at the university and in every other setting to continue to try and determine how we can move that forward. I totally agree with you, Sue, that we need to advance more and more people into the world of geriatrics.
And here's a follow-up question from Sue. How can we as professionals reduce the stigma associated with aging in general and Alzheimer's disease in particular?
Yeah, that's, again, a great question. We at the Alzheimer's Association have been battling the stigma for some time. There's certainly many people who still believe that memory loss is a normal part of aging, and the word Alzheimer's is a word that people don't even like to use. It's very similar to what those of us who are of an age that we can remember how cancer was addressed. And I can remember 40 years ago when you didn't say the word cancer, you whispered it. And Alzheimer's has been in that same position. People are very uncomfortable talking about the word Alzheimer's, talking about the disease. They say it's the disease that most people in every decade of life most fear now is Alzheimer's. It's no longer cancer. So I think, again, it's back to raising awareness, shouting from the rooftops that something needs to be done about Alzheimer's and dementia, being unafraid to talk about it with our families, being unafraid to talk about it in our churches, and in as many settings as we can. We need to just keep working on raising awareness.
I have a question from Diane Leaders. Could you repeat the stats of the growing numbers of Alzheimer's patients that you stated at the beginning of the webinar?
Yes. Currently at the moment, we would probably say there are more than 5 million, and that number by 2050 is going to 16 million. This, of course, is the result of the tremendous life expectancy that has been developed through advances in medicine. And, of course, what we all want is life expectancy with quality of life. So as these numbers are going to continue to increase, this truly is the public health crisis of our time.
Lois Beaudry is asking a question. What part does healthy eating play in lowering the rates of this disease? And a follow-up, what are some examples of health foods to explore?
A phrase that we use often here at the association is what's good for the heart is good for the brain. So thinking about healthy eating is something that we would strongly suggest. And it's back to fruits and vegetables, the wonderful diet that we often hear promoted by the American Heart Association and others. Healthy eating and healthy exercise probably are the two best things that anyone can do today. Regular exercise and healthy eating.
You know, Jan, I'd like to ask a question. You've been in the field of Alzheimer's and Alzheimer's prevention now since 2008, and you know, you work on a national level and you also work very, very closely here in Minnesota and North Dakota. So I'd just like for you to share your personal perceptions about perhaps some of the advancements that have been made regarding Alzheimer's, but also just what your opinion is of what work is still yet to do.
Thank you. Certainly, the research community needs to be broadened. the burden of this disease really requires an investment in treatments and in research. The work that has been done that waged a war on cancer now needs to turn into the war on Alzheimer's. We have a wonderful piece of federal legislation that is right now moving through Congress. It's called the Alzheimer's Accountability Act. And that piece of legislation relies on the research community to tell the Congress and the President every year what amount of dollars are needed that year to advance research. And we think of the very small amount, $500 million of money being spent on research compared to the huge amount, the billions of dollars that are being spent, over $200 billion each year spent on treating the disease. And we really have to change that formula to bring the research funding up to the level that it took. We know that we need to get research dollars for Alzheimer's up to the billion level. Advances were made in cancer, advances were made in HIV/AIDS, and they were all made by getting that research funding up to the billion-dollar level. And you can create all the activity going on, people learning from each other at the billion-dollar level. Something will come about that will create either something that will delay the progression, diminish the symptoms, or potentially create a cure. So certainly increase in research funding is something I've seen advance in the years I've been in this position, but it's an arena that we need a huge investment in if we're really going to battle the disease. In terms of what I have seen happen already, Act on Alzheimer's in Minnesota is being touted nationally as the #1 organization at work in battling this disease on all levels, on the county level, on the state level, on the community level. And they have really acknowledged that in Minnesota, a way to really address the disease is at the community level. So the 32 communities that are finding ways to address this disease, to take ownership of it within their city, are truly amazing. These might be communities that are, the majority of them geographical. They are not all geographical. Certainly the LGBT community is one, and the Jewish community is one that is not geographical in nature. But what I've seen in those situations is a real ownership in the Minnesota public, recognizing that there are things that can be done on the local level and taking advantage of that. In Minnesota, there has been legislation that worked at improving the competency of care. In last year's piece of legislation was a dementia training bill and assisted living. We know that in Minnesota, as in many places around the nation, more and more people with Alzheimer's or dementia are living in the assisted living structures. Probably 60% of those living in assisted living have Alzheimer's. So really advancing the way we care for people in those facilities is very important. So I've seen that as a strong piece of work in Minnesota as well. We're very lucky in Minnesota. One more thing that I would add, very lucky to have the Mayo Clinic always in our backyard. Certainly Dr. Ron Peterson, who heads the Alzheimer's Disease Research Center there, is a true resource, and we have many strong resources in Minnesota like Dr. Peterson. Dr. Peterson chairs the National Alzheimer's Council. I had mentioned the National Alzheimer's Project Act earlier. That again was a strong action that was taken nationally in the years I've been here. We worked hard to get that passed. The President signed it in January 2010, and creating a national plan to address the disease through a council that is headed by Dr. Peterson is going to provide, I think, really significant outcomes in the future.
Thanks so much, Jan. We do have a number of questions rolling in now. Kate Schaefer's asked 2 questions. Any thoughts on the role that employers should take in helping their employees who are caregivers as well?
Thank you for that question. Yes, we know that working caregivers have an even larger burden. We passed in Minnesota in 2013 the Caregiver Sick Leave Act. That was to require employers that currently offered sick leave, which isn't mandatory, but if an employer currently offers sick leave, we wanted to include caregiving for a person with dementia as part of what employers would provide. We do know that that bill was made into a law. We know that implementation of it has not been smooth. We know that there are caregivers who've had difficulty, even though they have accrued sick leave that they wish to use for a caregiving day or hours, whatever long it would be. We know that they are meeting not necessarily a smooth reaction on the part of their employer. So we know that employers that have taken part in caregiver sick leave have discovered that by doing that they had employees who were very grateful and truly loyal employees and grateful to have that benefit. So employers really could take a role here and really promote the use of sick leave for caregiving to their employees. We have programs here at the association where we go into employer settings and try and improve the knowledge that employers and human resource departments might have about the role of caregiving and about Alzheimer's and dementia. So I think this is a great question to raise, and I think there is a role for employers. We'll continue to push that down the road, but I would encourage anyone who's listening to the presentation to consider having that discussion with their employer and seeing if that employer is willing to recognize that the majority of us either have someone with in our family right now with the disease or we will have soon. So employers that can take the lead in making it comfortable for an employee to use caregiver sick leave and to be an understanding employer as to the burden that that caregiver is experiencing. Employers can go a long way in helping us with that.
And Kate has a follow-up question. Signs of early onset Alzheimer's disease often show up as performance issues in the workplace, perhaps even before diagnosis. Do you have any advice for employers?
Well, I said several times in the presentation that we really believe in early detection and diagnosis. If employees are feeling any change in their cognition, we urge them to talk to their physician, to be honest about what they're feeling. Certainly, people of all ages have been impacted with Alzheimer's. We think of it as a disease of people in their 80s and 90s, but that isn't true. I have an individual in my family suffering the disease at age 45. I have my mother diagnosed at 96. That entire lifespan certainly is impacted by the disease. The youngest person I've met is 28. So I would urge anyone who feels they're having a difficulty with their cognition, even though it seems fearful, to take an action and to really discuss that with their physician. And I think being brave at your place of employment is difficult. I know that the possibility of losing income is something that everyone would fear. Several years ago, we did get the Social Security Administration to add Alzheimer's disease to their list of compassionate allowance. So in that way, if you are diagnosed with Alzheimer's and you can no longer work, there is an avenue onto early Social Security, regardless of your age. 2 years onto Social Security in that form then gets you onto Medicare. So we do have some things in the last 5 years that we've been able to put into place that can help people who are still working and experience cognitive decline.
Jan Starla asks, at times we have calls from caregivers whose loved ones have not put a POA or a health care directive in place. Are there any other alternatives other than petitioning for guardianship conservatorship that families can pursue?
Certainly the health care directive and the POA are again things that need to be discussed early. I think that brings up a question that needs to be explored further. Unfortunately, I don't have a good answer to that question, but I think it calls out again the importance of shouting from the rooftops that these are issues to look at. My children have raised the issue with me, and I think even I thought I wasn't old enough to consider thinking about that. But we all have to address that issue. We have to become more comfortable with it. I think having a POA and a health care directive are things that need their own awareness campaign, and we need to work hard on increasing the numbers of Minnesotans that have completed those actions. I'm sorry I don't have a better answer except to suggest that we continue to raise awareness.
Lois has a question about medications. Looking towards prevention, can you address some of the prescribed medications that have been linked with Alzheimer's, and are statins on that list?
I would have to suggest that that is not my area of expertise, and I would be inaccurate if I were to try and make an educated guess, and I don't wish to do that. So I would certainly like to connect with her after the presentation, and I would get accurate information from another staff person at the association. My role has been public policy, and I'm a much better resource to you there.
Lois does have a follow-up question. I would think that support groups sharing their personal stories could be helpful. Is there an online resource available?
We totally agree with support groups. We ourselves operate 130 of them in our chapter area, and I cannot indicate what a strong resource that is for families. I know of individuals who attend up to 4 support groups at any given time. That's how much going to that activity helps them, and helps them be around other people who are experiencing the same thing. The online question, I know we have periodically raised the question of both telephone support groups and online support groups, and I don't believe that we have that taking place right now, but I can certainly take that back to our program area.
Okay, Janet wants to know about memory cafes. Memory cafes are a grassroots way for the community to support those with dementia. They may also help lessen the stigma of dementia. Are memory cafes widespread, and what can you say about them?
Yeah, great question again, and unfortunately they are not widespread. So back to those communities that we've been talking about, the 32 communities already established by Act on Alzheimer's. I think that is an activity that those communities will be looking at, and the more of them that we can get going across Minnesota and across the nation, the better. It's all part of becoming comfortable with the conversation, comfortable with the arena, and expanding those. I think that's a very effective way to both bond people, build relationships, and share resources. So yes, I support the work of memory cafes. We just need many, many more of them.
Sue has two more questions. Is funding for research on Alzheimer's on par with funding for other leading causes of death?
No, it is definitely not on par with other leading causes of death. It lags way behind many of the other disease groups. And, you know, we certainly welcome all the funding that goes to the other disease groups. We don't mean to diminish their funding in any way, but we still receive only a small fraction of the funding that goes to cancer, for example. So cancer has made great progress. They have survivors. There are no survivors of Alzheimer's, and we're definitely lagging behind. The Alzheimer's Association is the largest private funder of research. We have a major walk coming up this Saturday, the Twin Cities Walk to End Alzheimer's. There's also a walk in St. Cloud, and there are walks all over the country right now. We raise funds at all of these walks, and that goes to funding of research from the Alzheimer's Association as well. But we are lagging behind all the major diseases in research funding at the National Institute of Health.
And her follow-up question is, are there other states or countries that we can look to for best practices in Alzheimer's policy?
Great question. Thank you. There's a lot of great work going on in other places around the world, particularly in the UK and in Australia. They have been hosting international Alzheimer's conferences, most recently this last year in Denmark. So yes, there's a great deal of effort around the world. Some countries, Germany and Japan, I believe, aging even more rapidly than the rest of us. So yes, there's a great deal of work going on all around the world. The idea of the dementia-capable community that I've mentioned a few times is a very active piece of work going on in the UK. That, again, very recent work there as well. It's been in the last 2 years here in Minnesota, the last 2 years in the UK as well. So there's a lot of experimentation, both on the social aspects of living with Alzheimer's as well on the medical and research aspects.
Jocelyn has a question. What is the public health's role to encourage healthy brain and healthy aging?
I think that public health has a major role. Certainly, I've talked a lot today about things we've done with the Minnesota Department of Health. There are also county departments of health and a variety of ways that I think public health can really promote brain health, can offer education to their community, can help educate physicians. I think the public health arena has a wonderful opportunity to really take on this issue and brainstorm the ways that they can really promote early diagnosis, the way that they can promote usage of surveillance data and really promote brain health. Promote brain health messages. I know that there are people maybe with radio programs or through public radio or other situations where people can really talk about brain health messages and really talk about it in a way that the general audience can understand and refer people to the right sources for help, whether it's the Alzheimer's Association or to their physician. I think public health can maintain a very important role in raising awareness and keeping the message out there.
Okay, we have two more questions. Sonia wants to know, are you aware of any tapping used to help patients with Alzheimer's?
Tapping?
I believe she's referring to that type of therapy where you can tap on certain meridian points on the body and help to redirect some of the energy streams in the physical body. So do you know if this is used at all with Alzheimer's patients?
I'm not aware of it being used in any Alzheimer's situation. I can certainly go to our professional educators and ask that question. They may be aware, but I am not currently aware.
Okay, and she does follow up that it is the tapping therapy she was asking about. So, okay, there's one other question from Kristen. Are any interventions specifically targeting communities of color where rates of dementia are particularly high?
Thank you. That's a great question. I talked earlier about health equity and the importance of health equity. And certainly we know that in the African American and Hispanic populations, those rates are very high, much higher than for the Caucasian population. Another good thing that happened in Minnesota in last year's legislative session, there was a wonderful piece of legislation promoted largely by Volunteers of America with support from the Alzheimer's Association. And that was a piece of legislation that provided money for dementia outreach specifically to communities of color. So it's an attempt for the next 3 years to really expand knowledge of dementia and Alzheimer's into those communities in a very deliberate fashion. The first meeting on that effort is coming up within the next 2 weeks, but we're very excited to have Minnesota lead the nation in terms of recognizing the importance of that health equity issue and of trying to find a way to pass legislation to address it, and then to have the resources in the community at Volunteers of America, at the Alzheimer's Association, at the Minnesota Department of Health, all working together to expand our outreach and improve knowledge within those communities in the hopes of having earlier detection and diagnosis in those communities as well. Thank you for that question.
I do want to slip in one more question just because it's so excellent. This will be the last question, but Lois asks, wondering if you know if Alzheimer's is thought to be hereditary.
Let me answer that question in several ways. The largest factor being predictive of Alzheimer's is age. So if people who are my age, 1 in every 8 probably already have the disease in their body. At age 75, 1 in every 4. By age 85, 1 in every 2 to 3 people have Alzheimer's. So the largest factor is always going to be age-related. In terms of the hereditary question, though, there are families that carry a particular gene, and in those families they have very young onset of Alzheimer's and a very devastating situation in those families where individuals are often diagnosed by age 50, and many of them unfortunately have departed by age 60. So age will always be the factor. There is a hereditary component, and then they have identified the gene structures, the APOE4 and others, and so there's more study that's being done of that all the time. But that gene piece of it is considered to be a very small piece of those who actually do develop Alzheimer's. You're much more likely to develop Alzheimer's if you have great longevity in your family and you live beyond age 85.
Well, Jan, on behalf of everyone who's attended today, but especially MGS, I want to thank you so much for sharing your insights, your expertise, your experience, and your knowledge about Alzheimer's disease, about the Healthy Brain Initiative. But I think just the way you answered these questions was absolutely fascinating. I know I gained a lot of insight. So I'd like to share, those of you that are listening, you can forward any other questions that you have directly to Jan. There you see her email address on the screen, JMUELLER, jmueller@alz.org, at alz.org. So feel free to send her an email. You can also email us at mgs@info@mngero.org. I want to remind everybody that CEU certificates are available for today's webinar. They've been pre-approved for both the boards of social work and for nursing. They're free of charge if you're an MGS member and $25 for non-members. So we really encourage everybody to join MGS because you get free CEUs for this and all of the webinars that we have. The application is on our website at mngero.org. Also, as soon as you click out of this webinar, you're going to have a survey evaluation pop up on your screen. We ask you to take just a couple of minutes to fill that out. This is very important. If you want a CEU certificate or if you'd like information about joining MGS, you must fill out that survey, and then we'll respond directly to you in a couple of days. I want to bring everybody's attention to the follow-up webinar. The next webinar that's coming is October the 7th, only in a couple of weeks. And we're very pleased to have Dr. Rosalie Kane from the University of Minnesota talk about the ethics in aging. This is an issue that we've received many requests, and so we're very glad to bring that to you. Thank you so much for attending. I hope you enjoyed this. Please follow up any questions, and we hope you join us on the next webinar. And Jan, thank you again for an excellent presentation. We hope everybody enjoyed this. Take care.
You're all muted.